Right, thanks, Harjeet. Good evening, everyone. Welcome to the first meeting of Scrutiny Review Panel 3 for this year. This year we'll be looking at COVID inequalities and recovery. My name is Councillor Block and I'll be the chair for the panel this year, and my colleague Councillor Seema Kumar is vice chair to the panel. If we go to the agenda, well, before I go to the agenda, actually, I'll just quickly ask if you'd like to speak. It'd be great if you could use your raise hand function on Zoom if everyone's comfortable using that, and then I'll use that function to see who'd like to speak, ask questions, and go to you. Other than that, I think that's everything. So I'll go to agenda item one. So apologies for absence. I've had apologies from Councillor Tim Murter, who has just had a little baby boy. Harjeet, do you have any apologies?
Yes, so I've got Mr. Janpal Basran, who is the nominee from Ealing Community Network as a co-optee to this panel. He's at another meeting that's being held at the organisation this evening. Okay,
thank you, Harjeet. And item number 2, urgent matters. There are no urgent matters. Item 3, matters to be considered in private. Again, no matters to be considered in private. Item 4, declarations of interest. Do any members have any declarations of interest? Nope. Great. Okay, so we'll move on to item number 5, which is the panel operations for this year. And I'll hand over to you, Harjeet, to present this item.
Thank you, Chair. So the panel is being asked to agree its terms of reference and the outline work programme, which are appended to the report. And it also contains the co-option and external engagement arrangements that we are aware of so far. So you may want to ask councillors on the panel if they have any views on that and agree those items, please.
Yeah, so hopefully everybody's had a chance to look at the terms of reference and the works programme that was in the agenda. If anybody has any questions, do let me know. I can't see any hands up. Okay, great. So
you've got Councillor Gary Malcolm has a point about co-option.
I can't use, Chair, I can't use the hands-free function, so I put my thumbs up instead.
Okay, yes.
Thank you. Yeah, I've got no problems with the remit. That seems to cover a good sort of area of this sort of topic. One area which I think is useful would be a co-optee. And I think Harjeet was indicating the third meeting is when it would be most appropriate. And that would be someone from the Ealing Business Partnership who regularly have been on co-optees of meetings in the past. And I think we need to have a strong business in Ealing, and hopefully we can get someone from them to help. So I hope the committee would agree with that point.
Yep, I'm in agreement with that. Any other comments from members? No comments. Great. Okay, then. So yeah, Harjeet, if you would take note of that and invite somebody from the Ealing Business Partnership to attend panel number 3, that'd be great.
Yes, Chair.
And in that case, I think we can say that we agree in terms of reference and the provisional work programme for this item.
Yes, and just to note also that the education co-optees would be invited to the next meeting, which will be looking at elements of education.
Yes, and just to be clear that we all agree for Mr. Janpal Basran to be co-optee for this panel as well.
Yes. Thank you, Chair.
That's okay. So if we now move on to item 6, which is our kind of substantive item, I'm going to pass over to Dr. Madhi Gupta-Wright to present to us, and then I'll open up for members to ask questions.
Thanks very much, Councillor Block, and good evening, everybody. I'm just going to share my screen, so just bear with me a second while I get the slides up. Okay. So thank you very much. My name is Maddy Gupta-Wright. I'm a consultant in public health, and I'm joined by my colleague, Dr. Ellen Schwartz, on the call. We're part of Anna Bryden's team in public health in the council. And I'm here to present to you the latest progress on the COVID-19 integrated impact assessment on behalf of the cross-council steering group of officers who've worked with me since last autumn. We welcome the scrutiny panel's interest at this stage in the ongoing process. So I'll be talking about the context and aim of this work, defining what we mean by impacts and describing the process taken so far. And I'll show you some of the findings so far, but just to note that this work principally looks at direct COVID outcomes and by its very nature can't be in any way comprehensive. I'll give a flavour of some of the emerging recommendations from our internal discussions, and these recommendations are still being worked on at officer level. We've not started any of the governance process, so do bear this in mind. The development of the recommendations is very much in progress. So recognising that the COVID pandemic has exacerbated existing health, social and economic inequalities, the aim of this work has been to assess a wide range of complex and interrelated direct from the illness and indirect from the restrictions impacts of the pandemic upon Ealing's population and across the life course, and also to look at how these different impacts have threatened residents' health and well-being. A particular aim has been to understand who has been most significantly impacted and how this compounds already existing inequalities. And it's about highlighting the significance of the wider determinants of health or ill health, and therefore stressing the importance of preventative public health work. It will also provide an opportunity to identify assets and opportunities for recovery and improvements within the system long term. And it aims to develop a series of themed recommendations for the short, medium and long term to influence a number of key council and integrated care partnership actions, strategy and policy. And as mentioned, these are emerging at officer level currently. It's also to engage with people in communities in a more participatory way on the topic of inequalities, building relationships with people in the borough, and to work as a whole system to tackle these issues, recognising the strength, value and efficiency in doing so. So when we talk about impacts, we refer to those that are directly as a result of COVID illness and those that occur more indirectly from the restrictions of the pandemic or pressures that services have been under as a consequence. And of course, these impacts will be long lasting and have potential long-term consequences for the widening of inequalities in the borough. The process for this work has involved multiple components. These are analysis of quantitative data on principally the direct impacts of COVID, with some limited on indirect impacts, combined with information in national, regional and local literature on the impact of COVID, and then an element of limited but extremely valuable community engagement and consultation. And the whole process has been guided by a cross-council steering group with directors and assistant directors from across the council who continue at this current time to shape the recommendations in each of their areas. There are many points of influence for this work, particularly to note are the health and wellbeing strategy refresh for 2022 to 2027, and the council plan, particularly next year's, and the development of the integrated care partnership priorities and strategies. But you'll see a list there on my right, points of influence of other strategies and policies that this is hoping to influence. And at the bottom of this slide, it just highlights where we're at in the process and what we're looking towards in terms of reporting in August. So to start with a summary of findings from national literature on unequal impacts from COVID, the Health Foundation produced this very helpful infographic depicting 5 characteristics of groups most affected by some of the COVID impact or more affected by the COVID impact than others. These were people experiencing the highest level of deprivation, Black and minority ethnic communities, disabled people, young people, and health and social care workers. And of course, we should also recognise that many people will be affected by several of these inequalities, referring to the integrated nature of the impact of the pandemic. Another very influential piece of national literature on COVID impact has been the Public Health England COVID-19 review of disparities in risks and outcomes, which was published last year. In this slide, we've compared the headlines from this report against a summary of the findings from the Ealing data for March 2020 to March 2021, as there are clear patterns and similarities. Public Health England found the largest disparity in COVID outcomes was age. In Ealing, we saw working age adults most affected by infection, but the vast majority of those who sadly died were over 65 years. Much higher proportion of the COVID deaths in hospital were in men in Ealing. Public Health England also added that younger people were more likely to suffer more from the long-term economic impact of the pandemic. So for the next category, Public Health England found that people living with long-term health conditions were more likely to die. And similarly in Ealing, 91.4% of those admitted to hospital with more severe COVID illness had one or more long-term condition. Both national literature and local data suggests an unsurprising relationship with poverty. For Ealing, the highest infection has been concentrated in the west of the borough, and whilst limited data for both hospital admissions and deaths is available, it does appear that these are distributed along a gradient most likely attributed to deprivation. Public Health England highlighted the long-standing inequalities affecting Black, Asian and minority ethnic groups, which have been exacerbated. And in Ealing, wards with higher proportion of residents identifying in Black, Asian or minority ethnicities had higher total infection rates. Asian and Asian British groups appear to be disproportionately affected by hospital admissions for COVID in Ealing also. Whilst we aren't able locally to clearly separate the many other conditions at play when we look at the relationship between ethnicity and COVID, national and regional literature, where this has been done, concluded that even when you adjust for deprivation and other living conditions, there is still an effect attributed to ethnicity, which has been described as due to structural racism. Lastly, in Ealing, we are a relatively overcrowded borough, which will have had implications for COVID risk and indirect impacts. And we also have a high proportion of residents in lower skilled elementary occupations who were on the front line and therefore experienced greater COVID exposure than others. These maps show crudely the relationship I described in Ealing between COVID infection rates per 100,000 per ward in the purple and indices of multiple deprivation from 2019 in the red. I'm sure you can appreciate the pattern whereby the most deprived areas in the darkest red experience the most infection in darkest purple. This slide provides more detail on the disparity found in national literature and data for people from Black, Asian and minority ethnic groups. I draw your attention to two parts of this slide in particular. In the middle, the Office of National Statistics, which analysed for the first wave only the rate of death from COVID for different ethnic groups, and even when adjusting for other important factors such as age, geography, deprivation, and pre-existing health status, there was still a gradient where Black, African, Bangladeshi, and Black Caribbean ethnic groups were most affected. Further analysis by the Office of National Statistics in the second wave revealed that this disparity lessened for many ethnic groups, except for men and women in Bangladeshi and Pakistani ethnicity, where this pattern sadly continued. And right at the bottom of this slide, I refer to a report from the Scientific Pandemic Influenza Group on Behaviours, known as SPI-B, where they concluded that many of these disparities could be reduced by legal requirements for more COVID-safe practice in particular workplaces. Referring back to the pattern I described in Ealing data for ethnicity and COVID infection, this graph shows visually the pattern between wards listed here on my left, with high percentage of people identifying with Black, Asian and minority ethnicity, and a higher COVID infection rate for the whole year. This graph shows data for the hospital admissions in Ealing, and the proportion of which were for people from different ethnicities in orange against the proportions of each ethnic group living in the borough, according to Greater London Authority data projected for 2020. White groups were underrepresented in hospital admissions, and those categorised as other ethnic groups were overrepresented in COVID-related hospital admissions. It's a common assumption that the other ethnic group category more likely represents minority ethnic groups, which may have influenced the proportions in the Asian or Asian British and Black or Black British categories. So I won't go into huge detail on the next two slides. These are in the report, so you can see the wide array of regional and local literature which has been reviewed as part of this process. This has given really important insights into the inequalities experienced by different vulnerable groups, and to some degree the indirect impacts such as homelessness here and skills employment here. There are other sources that couldn't be included in these slides which have been influential. And on the next two slides, there are some highlights from discussions had in area task group meetings in March with community leaders and councillors from each of the following four areas. These were reflective discussions, independently facilitated, to have a conversation about what people thought had caused the exacerbation of inequalities in their particular areas and their ideas for collective action to tackle these issues. We took this approach because the groups had already been working together throughout the pandemic and established a degree of mutual trust, and because this seemed the best way, given the limited circumstances, to engage in conversations about inequalities with people from different geographical parts of the borough. Some of the highlights of the reflections gleaned from these meetings are here. Just to pick out some in no particular order of importance. For Acton, people felt there had been insufficient engagement in their area, and they didn't feel that the system was treating them as a whole. For Greenford and Perivale, some of the inequalities worsening were directly attributed to a loss of important infrastructure, community centres closing down, etc., and the wider impact of the charity sector's funding during the pandemic. Repeatedly, racial inequity and attitudinal discrimination were also identified as causes of inequalities. For Northolt, the inequalities were attributed to a feeling of neglect of Northolt infrastructure, the urban realm, and the fact that people didn't feel a part of Ealing at the borough level. They particularly highlighted the need for better and new physical places to meet, get support, interact, and develop a stronger sense of their community. For Southall, people felt there was a need to localise planning in the area so that homes reflected what the population of Southall needed, and they called for more attention to a hyper-local focus to needs assessment, development of strategy and policy overall. So all the findings and learnings from this process, both the quantitative data, the literature reviews, and the community engagement and consultation, have led to a range of themed areas of recommendation under development at officer level in the council, cross-council steering group. These themes listed here all emerging, although some are further along in their development than others. And on the next few slides, I'll be talking through some of these recommendations to give you some of the highlights. So I'm not going to dwell on the short-term recommendations listed here, but just to note that these have been feeding back into the Ealing COVID operational response throughout the pandemic. The theme of principles of working was really about key evidence-based approaches to tackling inequalities being embedded across the council and integrated care partnerships work. The emerging recommendations in this theme include a focus on true participatory engagement with people in the borough, asset-focused approaches, ensuring whole system involvement, and considering a problem across the life course, thinking about the causes of the causes, and particularly for health, those wider determinants of health, and embedding equity and fairness, including proactively tackling structural discrimination in all of our work. This slide just adds detail to the principle of working recommendation around participatory community engagement. This helpful diagram from Public Health England in 2015 depicts evidence-based community centre approaches to health and well-being. So these are some of the structures we may want to consider in that move towards a more participatory community engagement approach as part of that recommendation. And this slide helps to explain what we mean by delivering universal support, which is scaled in proportion to need, another of the recommendations emerging in the principles of working theme. This is otherwise known as proportionate universalism, a phrase coined by Sir Michael Marmot in the Strategic Review of Health Inequalities in England in 2010 and later reinforced in 2020. This diagram gives the example of parenting support and how, in order to tackle inequalities systematically at a population level, you need a universal offer of support with degrees of increasing intensity of support for those smaller proportions of the population who are most socially and economically disadvantaged. Our emerging recommendation is that this principle of working could guide policy interventions and services more explicitly. So to move on to give you a flavour of some of the other themes of medium and long-term emerging recommendations, the housing theme focuses somewhat on property licensing as a useful tool to tackle poor housing conditions and improve the management for tenants, particularly in private rented accommodation. There are also some important emerging recommendations around lobbying national government for increased support to these tenants. In employment and skills, the emerging recommendations are currently in 4 themes: to assist those with health barriers to work back into supported and healthier employment, to engage with employers to develop and promote healthy work best practice, to support the upskilling of a range of sectors in order to provide better entry-level recruitment into sustainable and healthy work options, and a range of other recommendations related to specific age groups, sectors, and a commitment to better community engagement on the topic of employment skills development for the borough. The emerging recommendations in the children and young people theme have been guided by a recent draft update to a children and young people's joint strategic needs assessment. To highlight a couple of the recommendations, there's a particular focus on the mental health and well-being of children and young people, on prevention and early intervention of delays in school readiness and attainment gaps, and targeted intervention proportionate to need, particularly for children in worse socioeconomic circumstances. A somewhat cross-cutting theme of mental health and well-being currently has a set of emerging recommendations which look to reset commitment to making every contact count as an approach, using structures such as community champions programs, working closely within the integrated care partnership, and assessing the unequal impact of an array of different violences during the pandemic. For active living, ageing, and adult social care, the emerging recommendations highlight the importance of community participation, links with the social prescribing landscape, and the age and disability-friendly design of urban realm, particularly in areas with greatest inequality, alongside the importance of social care providers operating to build community wealth. For customer support and digital inclusion, emerging recommendations echo many of the principles of working recommendations in terms of a focus on holistic support, prevention and early intervention, and hyperlocal access to the support available. Specifically for digital inclusion, there are various emerging recommendations about hardware, software, and training, and ongoing support to upskill the population, as well as recognising the need for continuing alternatives to digital offers. For the recovery of public health services, emerging recommendations include work within the integrated care partnership to prioritise the tackling of inequality at the point of prevention of health problems, and the connections between preventative health services and services which are targeted at key vulnerable groups with the social prescribing landscape in the borough. So what are the next steps for this whole process? Well, to develop and agree the recommendations in all themed areas internally with council officers, so we can move to begin wider consultation and the all-important governance processes around these. We hope to produce a final report in August. There'll be ongoing relational work with key forums and boards to continue collaborative working, particularly as the integrated care partnership develops. There'll be ongoing work to ensure optimum impact in all of the key points of influence I described at the beginning. We hope to produce an executive summary of this work to become the annual public health report for this year. And we hope to use this process and the findings, including the annual public health report, as a community engagement tool, disseminating the report and having discussions with the Ealing population. We also hope to use the findings and recommendations as the basis on which to build the Health and Wellbeing Strategy 2022 to 2027. Many thanks for listening. Ellen and I would be happy to take any questions and take any feedback. I'll stop there. And just to note, of course, that the report that you have, that you've had shared with you has a lot more detail. So I'm happy to go back to any of the slides with any questions on specific set areas of recommendations, etc. Thank you.
Thank you so much, Maddie. I'll open up to questions from members. So does anybody have any questions for Maddie or Ellen on this presentation? Councillor Malcolm.
Thank you, Chair. I've got two questions. The first one relates to page 32 of 50 in the report, which talks about the state of homelessness in Ealing. In the first year or so of COVID, some of the government restrictions put on landlords in terms of stopping evictions and debt collections had a welcoming effect on that, where there were fewer people who were made homeless, and people who were homeless were given a slightly easier time. Can you just give an update on what's happening on that front and how that's likely to pad out in the next 6 or 9 months' time, because that's going to be a factor as well. And then my second question relates to sort of vaccine uptakes. And if we look at page, let me look at page 37, I think it is, there is what I know from another committee is we've got a much lower number of people vaccinated, whether it's the first vaccine or both vaccines, in the borough compared to the average or even London. Is that a problem with the uptake rate in Ealing, so that for every 100 people offered the vaccine, a lower than average people are taking that offer upwards? Or is it that we're not being given enough vaccines to actually distribute? Because I think that is a concern.
Thanks, Councillor Malcolm. I'll address the first question and then I will hand over to my colleague Ellen to talk about the vaccination point if I can. So on the homelessness issue, we do have a recommendation in the housing, in the emerging theme of recommendations on housing, to lobby national government, to continue lobbying national government to extend and make watertight those protections against eviction in order to help prevent homelessness. I can't speak to the precise activities of our housing colleagues on ongoing time on that issue. However, I do know that there was some work underway to understand when the eviction protection would be lifted. We were assuming that would come into play at the same time as now national restrictions are lifted at the end of July. So a great deal of concern around that. And of course, whilst homelessness itself during the pandemic has actually been curbed and in its numbers, due to that protection against eviction. I know housing colleagues are extremely concerned that that will no longer be the case once that eviction protection has been lifted. So yes, I can't speak to the detail of the activities they're undertaking to progress that internally, but I do know there was lobbying and continuing will to lobby the national government to reconsider that protection being lifted particularly at this point in time. Ellen, are you able to address the vaccine question?
Yes. So first of all, thank you for the question. In general terms, I have to say, so we're in the middle, not in the middle, but towards the end of the London vaccine sprint. As you rightly say, London is doing less well as compared to other areas in the UK in terms of COVID vaccine uptake. And that is reflected across all vaccines for various reasons, amongst those inequality patterns that are more extreme in London than elsewhere. With regards to the uptake of the COVID vaccinations, we're actually now catching up. The rate of increase in London is higher than in any other region across England. So we're speeding up increasingly and we're closing the gap. And Ealing is not a particular outlier at all. Ealing is doing quite well. But in terms of what happened during the pandemic and what is reflected in this report is the acknowledgement and the attempt to measure inequalities and to do that by both quantifying it and demonstrating it in qualitative terms and working up ideas on how to address it. And vaccination is a really good example of where we have done really extreme strides in Ealing across Northwest London and across London nationally, of course, is in terms of working closely across, joining up. So this is, of course, as we all know, the vaccine rollout is an NHS undertaking, but it has led to a join up between the different organizations. And while historically the NHS is really talking about patients, not communities, and inequality of within communities, this is now firmly part of the conversation around vaccinations. And it's really very encouraging to see how we're drilling down and reaching out into community groups and individuals who are suffering inequalities to make sure that they are receiving the vaccine. I just need to get near a power source. Just excuse me 1 second.
Councillor Markham, did you want to come back?
I suppose the first part of the vaccination question I didn't think I got an answer to, which was there were two elements. One is the uptake rate lower, which I think you gave the answer. That was true in Ealing. The other one was, are we in Ealing being given fewer vaccines than we need, basically, or compared to other boroughs around the country? Because clearly we were so far behind the average. It's probably a combination of the two, but given what you said about London, its diverse communities and some of the initial COVID death rates in certain groups, it sort of seems counterintuitive to give London fewer vaccines than more vaccines. I know everyone wants the same vaccines, but would you agree that Ealing seems to have been given fewer vaccines than per capita, or is that not the case? Because I've not seen that stat anywhere.
So thank you for this. So I don't think that's the case. I think what happened, particularly in the first couple of months of the vaccine rollout, is that it was primarily given to healthcare staff, social care staff who weren't necessarily residents in London. So we have used vaccine not necessarily on our own residents. The other issue is that we have a yet unquantifiable number of so-called unregistered individuals in London and in Ealing also. So that has led to us actually using a lot of vaccine. This has been addressed now. We have received, where at the moment there's no shortage of vaccine. We're just in the kind of current weeks, we have very good stocks, increasing stocks and increasing range of vaccination, types of vaccination. So I don't think there is a concern around kind of unequal distribution and Ealing missing out.
Thank you.
Do I have any other members who would like to ask a question? Councillor Luswadi, please.
Hi there. Can you hear me okay?
Yep, we can.
Yep. I was interested in the next steps, so the things that you're going to engage in next. One of the points is to use the study or the inquiry as an engagement tool, community engagement tool. I was just wondering how that was going to happen, how you envisage that happening, because I think it's really important that the local community do take ownership of any inquiry or any sort of study, and often it doesn't happen. So what can you do to ensure that the local community will engage with it and take ownership of it?
Sure, thanks very much for the question, Councillor Luswadi. A few points actually. So this, as an executive summary, as I mentioned, this is going to become the annual public health report, which is a published document on the council's website. And that version of it will of course need to be very language friendly, very jargon free, very easy to understand, very broken down into key messages for the general population. And so we would hope that that's a digestible way to at least get the information out there, recognising that that isn't a method of engagement in itself, but that will be our way to communicate some of the highlights from this whole process to the general public in Ealing. And then I guess because we are hoping for it to become the foundations on which to build the health and wellbeing strategy. And in order to develop that strategy, we go through a very large stakeholder engagement, wider public consultation and engagement process. So we would also hope to use the findings of this report as a tool within that health and wellbeing strategy process. I think also there is, of course, a strong appetite in the council at present to continue to improve the way we engage with different communities, particularly picking up Ellen's point about finding communities and community groups and individuals with whom we haven't previously engaged well. And that has certainly been improved during the pandemic, and we would hope to build on that. But there's an appetite, of course, to improve the kind of community engagement approach for the council, and that be embedded as part of a community engagement strategy. So I would also hope that that this can be a tool to use as part of that community engagement strategy and process to talk to people in the borough about inequalities and take the conversations we've already had around collective ideas for how to tackle these to another level and to continue that ongoing conversation. Of course, at this point in time, we might have, as we have done, assessed the kind of depth and breadth of some of the inequalities post-COVID, but these inequalities aren't going to go away quickly, and they're not going to be something that we can resolve immediately. So it will be an ongoing topic for discussion with community groups. So hopefully this will set some of the scene for some of those conversations.
Councillor Luswadi, would you like to come back?
And that's fine. No, that was very helpful. Thank you.
Great. Do I have anybody else who'd like to ask a question? I'm not seeing any hands up. Okay, well, I just wanted to, well, firstly, thank you so much for that presentation. And this impact assessment, I think, looks like it's going to be a great piece of work for the council to build their work on. I wanted to ask about the vulnerable groups that you mentioned who have been more affected, the disabled and people with long-term conditions. And with the removal of restrictions from next week, amongst this the rising of cases, how what are we looking at in that very short term kind of actions that we can take to ensure that it's not kind of freedom for those of us who are healthy and feel confident to go out, and others who are more worried about their health suddenly feeling that it's not quite so safe for them.
Thanks, Councillor Block. Really, really important question. And I may bring Ellen in as well to support the answer on this one. I think we in public health and in the council have been discussing the way that we need to carefully communicate the risk and responsibility to the wider Ealing population as we come to that point of restrictions and enforcement being lifted. I think the way we're viewing it is that whilst enforcement is lifted, the recommendations to do all the non-pharmaceutical public health interventions to maintain attention to good hand washing, to space between those that you don't live with, it's particularly indoors, to wearing face coverings indoors in crowded areas or in other settings where either other individuals might feel particularly at risk, and that will include some of those vulnerable groups that you're talking about. So it's finding a way to communicate that kind of personal risk and responsibility that we all need to understand to sort of protect ourselves and everyone around us. And certainly that will need to be a strong part of communication and community engagement work as we go into this phase. Yeah, I think I don't know, Ellen, if you want to come in at that point.
Yeah, so really important question, and it's a really critical time right now for the most vulnerable members of our communities. So whilst the legislative element is falling away, and therefore the enforcement element for us as a council, as Maddie's saying, we are continuing with communicating the guidance that the accumulated evidence that we have gained over more than a year of living with this pandemic. And it's basically three pillars of a message consisting of three pillars. One is this COVID safe behavior that Maddie has just outlined. The other is around testing when appropriate, either repeatedly asymptomatically or when people have symptoms with a PCR, and isolate. And the third is get vaccinated twice. And this is the consistency of this message. And then, and particularly around the vaccination for those vulnerable groups, they will have been reached out to by the NHS, supported by the council repeatedly to make sure that we're maximizing uptake of vaccination going forwards, thinking from now pretty much end of this week into some booster vaccinations, flu vaccinations, to make these most vulnerable people clinically and in all these three pillars as protected as possible.
And just coming back on that, for those people who are immunocompromised or going through some kind of treatment where they can't be vaccinated, is there any kind of other support in terms of mental health, or that they will very much feel like they have to isolate even more so, and that the support around well-being as well, because it could be a frightening time for some people.
Completely. So if I can just get quickly, before I know you want to come in, Maddie, just on vaccinations, people who are immunocompromised can get vaccinated. Okay. Contraindications to the vaccination are very, very few. And it's those who are immunocompromised who are particularly targeted, where also the guidelines are slightly different, where the clinician looking after these individuals makes a decision sometimes to vaccinate outside other kind of cohorts and indication groups. So they mostly can get vaccinated. And of course, take your point around mental health. There's a lot of mental health discussions and join up around mental health going on nationally and across London. But Maddie, you want to also answer this, I think.
Yeah, I mean, I just wanted to pick up the fact that there's a very careful balance here between targeting people who might see themselves or have been defined by the system as more vulnerable, rather than actually providing guidance and careful communication to all of us around our own personal responsibility to the others around us. Because I think, you know, putting myself in the shoes of somebody in that position, it's not just, of course, in fact, very little that they can do. There are a host of things they can do personally, but it relies very much on the people around them being aware of their own clinical risk, and them also taking the responsibility for all those actions, including themselves getting vaccinated as well, which you know, will be part of the picture. And the same applies for mental health and wellbeing resources and services to some degree, although the approach of proportionate universalism that I described, I think, is a very useful one here. So as the sort of plans around building more mental health resilience in the community and what's needed in order to be able to do that, so what kind of services, what kind of support, what kind of improvements of existing services and support that are needed, I think there needs to be careful attention to a universal offer for everyone, because everybody will have experienced a particular kind of pandemic, which is unique to them and may have had mental health and wellbeing implications, but also that we recognise that there are groups that will need a higher intensity of support than others, and that they need to be able to access that in a kind of timely way. So it's a careful balance for me around that sort of targeting of both those services, mental health and wellbeing, and the communications messages, and also making it kind of everybody's business and everybody's responsibility to try and stick to those strong recommendations that we are going to maintain, even though the legislative bit has gone.
Thank you, Nadie. I had another question about BME communities, which we saw from your presentation were disproportionately affected. And in terms of, I wanted to ask how the NHS and our council staff were affected, and what we can do internally to ensure that we are protecting our vulnerable groups as an employer and working with, you know, our partners in terms of that.
So in terms of impact on kind of the council workforce, it's, you know, I imagine it to be very similar to the impact that we've seen across the population, and those disparities in, you know, Black, Asian and minority ethnicity being there as much as they would be if we were to look at a larger proportion of people. So of course that's a great concern when we start talking to council officers about their you know, how they feel about the non-pharmaceutical interventions that they've been able to take, but also their risk and their the feeling that they might have had around being discriminated against during the process of the pandemic. I know there's a lot of work going on within the council workforce to sort of address or readdress, if you like, conversations around equality, very much focusing on ethnicity, and to get a kind of council officer, very broad council officer participation in that process of strategy development for the council, what actions need to be taken to actually protect and make sure that anyone of any ethnicity feels part of that decision-making process, but also part of protected and have their sort of their wider welfare during a pandemic considered on an equal playing kind of level to everybody. In terms of the sort of pandemic response and the council's work outwards into the population, Ellen will have talked briefly earlier about the vaccination delivery and working with particular communities to ensure that people have access to information around vaccine that they understand, that's meaningful to them, that kind of addresses some of the concerns, but also work has been ongoing to ask to work with community groups where they want to set up their own kind of information sessions and events, and where we can support. So that will also have been part of that process. But I think there's still a lot to do on addressing kind of ethnic disparities in health more generally, and it will of course be very high on the agendas of integrated care partnership working, of council working going forward, and of the border system, including working with the voluntary and community sector, of course. Ellen, I don't know whether you want to add anything to that.
No, I think that was very comprehensive.
Yeah, I think one of the points that I'm trying to make is that if you look at the kind of inequalities that we're talking about and how it's affected our ethnic minority communities, and you look at the council staff, you see a reflection of some of that equality there, where our kind of senior leadership tend to be more male and white. And then if we look at some of our groups of our staff who have been on the front line, if you look at the care workers, you're probably looking at more diverse and less well paid off. And so, is there that real kind of reflective looking inwards happening as well as looking outwards, and trying to ensure that we protect our community? Because I think that we need to make sure that we're doing that ourselves as a council, as well as looking outward towards our community.
Yeah, sure. So I can mention briefly a piece of work that has been going on in the council part of that piece that I alluded to around equality and anti-discrimination for the council's workforce includes a look at tiers of workforce and how, who's making it to what level and why, and what structural barriers are to other groups making it to those levels, because of course, as you've described, there is certainly a clear disparity, as there are sadly with many large employing institutions. So that work internally has looked at that, and I can't speak to the detail of that, but I know there are ongoing conversations, even down to directorate level and department level, to talk about, what do we all want to do in small departments and directors to improve that recruitment equity, recruitment process, and also the kind of the early pathways into that. So what's the preamble to those recruitment processes that need to be equitable as well. There's also the Race Equality Commission, of course, which will provide recommendations to the council later this year, I believe, and we are very linked in with the work of the Race Equality Commission with this integrated impact assessment to ensure that we're learning from each other and we're able to kind of feed in the findings of the Race Equality Commission, although it might not influence the actual final report of this integrated impact assessment, certainly dovetail into things like the health and wellbeing strategy and the kind of further points of influence. And I think you touch on a really important point for us as what we're now knowing as an anchor institution, as an institution that has a responsibility to build community wealth in the borough, around employment and economy, but also around equity and anti-discrimination and the tackling of structural racism. So we certainly have a huge role to play. I think the focus internally will help, because we obviously need to get things sorted as well to be able to be that anchor institution, but lots of conversations around our role in influencing other institutions and employers in the borough when we can.
Thank you, Maddie. Do I have anybody else who would like to? Oh, Councillor Kumar, please come in.
I think my reaction button was playing up before, so okay, right. I think I'm on now, right? No, my concern was on the. I think there's an echo. Can you hear me clearly now? Or? Yeah. No, my concern was on the homeless and the rough sleeping, because I noticed that in the summary of your findings, you've included people who may have lost jobs or relationship breakdowns, domestic violence, even prison release. So, I mean, I'm just wondering what, what category are they being put into? Is it homeless, or are they also rough sleeping? I mean, I do know there is a degree of that happening, but how is that being tackled? Because that will give such a sense of insecurity anyway. And also the fact that, the highest rates of infection and burnout and the reliance of inexperienced and temporary agency staff. I mean, that's all pretty unsettling. So where does this particular group of people stand? I mean, what are we going to be doing about that, and how is that being tackled? Because the NHS is under obviously a huge amount of pressure, and it's going to increase. So if they're not getting the help they need, how are we going to be addressing that? I mean, I know it's a 3-in-1 question, but I am concerned about that, because I find that category of people who were working, who were in employment, and because of the whole pandemic situation and other reasons, they're now, what are they classified as, and what help are they being given? Sort of extra. Are there issues being addressed? In a different way, or are they getting more priority? How does that? How is that going to work out?
Thanks, Councillor Kumar. And we've obviously considered those experiencing homeless and rough sleepers within this report, and relied quite a lot, sadly, on regional and local literature as opposed to really good local data, although the housing team are able to tell us, of course, numbers of homeless at any one time and those that are in temporary accommodation. And as I mentioned earlier, that number has actually, been decreased during the pandemic due to the protection against eviction. But certainly housing colleagues are expecting that to not be the case going forward, and for there to be a significant, I guess, bounce back in homelessness and rough sleeping in the borough, and particularly potentially a new problem of homelessness in those that you also described, whereby people have lost their jobs and become, more economically insecure during the pandemic as a new problem in their lives. So certainly a key group in terms of inequalities, and always have been for us in public health, a focus of inequality work in public health. For example, drug and alcohol services work very closely with outreach teams in the homelessness sector to ensure that people who are homeless, as we know, who have a higher risk for drug and alcohol problems, also get good access to services. There's been work ongoing with Ellen and colleagues to ensure that those people who are homeless at the current time or rough sleeping also get priority access for vaccines, or certainly get really good access to vaccines. And we need to think, obviously, very carefully about how we do that through the trusted relationships they have with outreach workers, etc. But I think it's a broader question that I won't be able to answer in full at the moment, and it will be something that evolves with time as we recover a little bit from the pandemic and work with the Integrated Care Partnership on priorities around inequalities, particularly around homelessness health, and also not just with our local ICP colleagues, but more regionally and nationally with Public Health England colleagues who also work on homeless health. So probably one for us to keep on the radar and come back to in terms of how we're going to kind of tackle them as a population group and as a vulnerable cohort. Ellen, I don't know whether you want to add anything there.
Yeah, obviously your question was a wider one in terms of how do we tackle the underlying problems, and how do we get, how do we help support individuals in those situations out of the situations. And that's the kind of much more tricky question. And in terms of what happened so far during the pandemic, which I find quite encouraging with regards to those groups that we sometimes call inclusion health groups. So they're not just homeless, they are in various categories, whether they're sex workers or have a substance issue, or they are rough sleepers. And there's a long list of so-called inclusion health groups. There has been a remarkable join-up between local authorities, NHS providers, not just kind of local NHS, but specific groups that are targeted, they're providing joined up services to these communities, or these individuals rather, to move away from this approach to just provide one service, like for instance vaccinations, but to be a bit more, to ask, for instance, homeless people, what is a priority for you? Is it dental health or is it mental health? And can we join that up and provide the vaccination at the same time? And the other thing that's happening, very encouraging, is that it's a start for an ongoing engagement. It's just not just flying in and flying out. So they can still be considered, and I know that wasn't the background of your question, which was much more kind of holistic, but in terms of service join-up and across organizations with the dedicated local knowledge that we as a council can provide, that is really improving, and it's palpable. In terms of addressing the underlying issues, I have to resort to the same answer like Maddie, that we can't answer that easily, but there is something to build on in terms of the relationship with those individuals and amongst the organizations.
Yeah, I mean, I knew that it was a broader question, and obviously, with all the changes and everything, it's going to, there will be work in progress. But I just wanted to mention, this is a comment, not a question as such, but I mean, during the pandemic time, I asked one of the homeless concern organizations what was it that they needed most. People were giving food, and they were all and clothing and whatever, but what was it that they felt they needed real help with? And they told me they needed a doctor. So I organized a doctor to come down and see the homeless people on that particular afternoon. And, they were reluctant at first and then I kind of did the secretarial work and said, look, I'll show you in. The church had opened their hall, especially to have a one-to-one, so they'd have so it took a while, probably half an hour or so, to build their confidence. But I mean, at least 3 or 4 of them, when I told them, okay, do you want to see the doctor? They said yes. But then their question to me was, are you actually saying that a doctor is willing to see us? Does a doctor really want to see us? You mean we are actually going to be seeing one? And they had all sorts of issues. They needed dressing to their wounds, and a lot of dental issues have been flagged up. This was discussed at OSP last week. But I think the vaccine thing is fine. I think there aren't too many problems, but that's what they said. So, it'd be something to, absorb and keep in your minds, that is what even the homeless organizations asked for, not food, not anything else, but that. Because they were staying in hotels or hostels or whatever, and that was working out fine. There were many, about 18 to 20, who did not want to be given any accommodation. They chose to sleep rough, which was a choice that they made. But that was the key problem. So it would be something to bear in mind when you are having discussions, and hope it will be a bit useful.
Thank you. Definitely.
Thanks very much. Councillor Block, I think you're on mute, sorry.
Thank you. Sorry about that, Maddie. I was just asking if there's anybody else who wanted to ask any questions or come in at this point. No. Right. Well, in that case, thank you so much, Maddie, and thank you so much, Ellen. That was really, really interesting, and it's good to see how comprehensive the assessment, impact assessment that you're doing is, and really, I think, encouraging that how much you're looking into those kind of interdependent causes to get down to the root causes rather than often looking at the kind of symptoms and trying to work on that. So that's encouraging. So in terms of recommendations, how do you, will Maddie and Ellen be coming back? There's a bit of an echo to the panel.
Not unless they're needed, but the panel would make recommendations at the end of its work. So the officers would take the comments on board as they're progressing the work on this. But any specific recommendations would be formed once you've completed your review, because you've got other meetings.
Yeah, because I was just thinking the report isn't actually finished till August, so it'd be good for us to be able to see the finished reports at some point, and I suppose that could come to us without Maddie and Ellen coming back to the panel.
The only problem with just receiving a report would be if you did have any questions around the contents, then there needed to be somebody to answer those.
Okay. Okay, well, I'm just thinking, because it's not completed, how the final report would feed into our final report as such. The timings don't quite match up. But
may I suggest that once the report is complete in August, it is circulated to the panel, and then once you've read it, you can decide how you want to progress with it. Whether there might be questions that could be answered outside of the formal meetings, or you feel that the officers need to be invited back to a future meeting. So that's something you could decide once you receive the final report.
Yep, that sounds good to me. Is everybody else happy with that course of action?
Yep, agreed.
Agreed, great. Okay, well, thank you so much, Maddie. Thank you so much, Ellen. We really appreciate that, and we look forward to seeing that full report and seeing the actions that come out of that.
Thanks very much, everybody.
Yeah, thanks for your comments and questions, really helpful.
Thanks. Right, so I think that concludes all of our kind of substantive items. So we just go to item number 7, which is the date of the next meeting, which will be the 6th of October. Okay, thank you everyone for this evening. Thanks to everyone for coming along, and yeah, I look